Hello, this talk is about the relative stagnation of OCT in clinical cardiology between 2000 and 2015, and how it affects the long-awaited clinical trials that are finally coming underway. This is another talk in the OCT series, and like the others, one objective is to support those interested in a career in academic medicine and OCT in particular. This talk is a little unusual because a significant portion will be directed at interventional cardiologists today, hopefully providing useful information to apply OCT to their patients. In addition, or at least understanding OCT, in addition, as we are finally moving to finally seeing solid outcome studies after 2 decades of waiting. Um, I'd like to also discuss the impact of this, in my opinion, relatively long stagnation on the clinical trials that are occurring currently. Um, this is not meant as a history election of OCT. We've already done one of those, but the past events are relative to OCT now and OCT's future. For instance, discussing imaging through blood, OCT guide wires, and are you really seeing what you think you're seeing? A prominent cardiovascular surgeon said to me the other day, OCT is a great research tool. I wish I could, but I couldn't argue with him that it was a powerful clinical modality after uh, we introduced it as a light lab 20 years ago. Um, I am grateful after so long, however, that outcome studies are finally underway, and also grateful to the new generation of clinical scientists, along with the companies that are doing it, moving OCT forward. Between 1993 and 2000, the progress of OCT in non transparent tissue, particularly cardiology, was rapid. It went from widespread skepticism that OCT could ever work in non-transparent tissue to in vivo intravascular imaging technology. We formed Light Lab Imaging at the end of the last millennium to develop OCT as a clinical modality for interventional cardiologists, along with the technology to be used in other specialties. I have previously and will continue to argue that between 2000 and 2015, particularly frustratingly, the progress of clinical OCT can be considered relatively stagnant, and having um, dedicated 25 years of my life or more to it, it's been frustrating. By 2010, pessimism was substantial that OCT would even work, and I completely understand why. Not speaking for anyone else, I admit making numerous bad decisions 2 decades ago that contributed to the stagnation. The field has been and is still in need of strong outcome data that addresses morbidity and mortality, which unfortunately did not occur significantly over this period, um, though this isn't the only issue. Physicians depend on morbidity and mortality data, such as MACE, and great images and case studies are not substitutes. In addition, several other factors, I will argue, have been holding back OCT from general acceptance. I will be discussing OCT's role both in PCI significant lesions and ACS, but also uh, lesion specific intervention to prevent ACS as they are uh, linked. Please again bear in mind with some of the going back in history, it's relative to the point. What do we want? We want OCT to improve morbidity and mortality in our patients. Be confident we know what we are looking at when in an OCT image. Be able to image through blood. Have an imaging system and a guide wire would be a dramatic leap, and don't lengthen the procedure time, even shorten it. Now, for people who aren't in medicine, they don't understand that the slightest thing we look at morbidity and mortality data. I mean, this is one on fish oil. Um, in heart failure, we look at does it affect morbidity and mortality, or oxygen. So, sticking a catheter down a coronary artery, we absolutely need morbidity and mortality data. We can't just rely on somebody telling us they think it's great. Um, so here's two example papers of finally showing that things are changing. So since 2015, things, like I said, are changing. The top is a Lancet paper that was funded by St. Jude, which was a start. I believe it was funded by St. Jude. And Abbott is moving forward with other trials. The link at the bottom is to an Abbott video with a presentation from three interventional cardiologists who talk about applying OCT. I think it's helpful because at most I'm an invasive cardiologist and not an interventional cardiologist, and hearing it from people who are in the interventional field I think is better. In spite of the fact I founded Light Lab Imaging, I have no affiliation with Abbott. These interventionalists talk about OCT actually cutting down dye use and procedure time, which is better for them to explain than me. So briefly, OCT is imaging at the level of a biopsy without tissue removal and at super video rate. It's FDA approved in a lot of areas, but the stagnation is occurring in a lot of these other areas for the same reason. OCT in transparent tissue, imaging in transparent tissue, is a different embodiment. It cannot be compared to OCT imaging um, uh, in the coronary artery, for instance. First of all, OCT was previously called LCI, or optical low coherence reflectometry, OLCR. So it dates back several decades from the 1990s. But um, the first on this slide, this is something we did in 1999. Where does OCT actually work? And for the most part, it came out to be true. But again, this talk is not directed at the eye, and I drive that point forward because I saw a presentation by an interventional cardiologist who said we're taking retinal images of the coronary. And this is far from the truth. Imaging in non-transparent tissue is far different than imaging in a coronary artery. And this is covered in our earlier penetration presentations. And actually, if you used a cardiovascular system in the eye, it would cause serious damage, and there's a chance it actually could detonate the eye if the right system was used. And the image on the left is using an ophthalmologic system on a coronary artery, and it looks like those images they get from deep space thermal imaging. I mean, you can't make out any structure. On the right is a cardiovascular system. Now, in fairness, these are separated by, like 10 years, I think, just because we don't go around imaging coronary arteries with ophthalmologic systems anymore. But you still would get a very similar result. The maximum penetration is only about 250 microns. So my name is Mark Brezinski. I did publish with Jim Fujimoto, like the first 8 OCT papers in cardiology. And the rest of it you can read on the slide. I like to put background slides in the middle because it sort of gets boring when somebody presents their background in right up front. But one of the points I want to make out, because it's relevant to this whole concept of this stagnation, is I'm a basic scientist, I'm a clinician, I do quantum mechanics. What I am absolutely not is a clinical scientist, and I am not qualified to run clinical trials. And you can see the lack of understanding of the need for clinical science, what a clinical scientist is, on my LinkedIn page like a year ago, because the number one thing by a factor of 3 people listed as my expertise was running clinical trials over OCT, over quantum mechanics, over engineering, over medicine, over cardiology. People don't, you get the sense people don't even know what a clinical scientist is. But what I know is I'm a clinical science moron. And in the textbook I wrote on OCT, one of the only chapters I didn't write was the chapter on clinical trials. So again, the fact that so many people listed me as a clinical trials expert, just is sort of indicates part of the pathology in the problem. And this concern over OCT's progress isn't in hindsight, as I published a lot of paper, or a significant number of papers, between 2006 and 2014 describing the problem, including in major journals, Circulation, JACC, Nature, in addition to websites, YouTube videos. Not only did the acceptance of the technology get delayed, but adjuvant techniques, for instance, imaging beyond pure structural imaging, took a hit. The NIH stopped funding it, and I'm going to go back into that. Imaging through blood, which we developed a way to image through blood, stopped dead. Around 2010, I had my first NIH grant not funded, and it was on adjuvant techniques. And their argument was, you got to prove that this actually works in patients. We're not just going to keep funding it, advancing the technology and advancing techniques in it, unless you actually can prove it does something. And so that was a wake-up call for me, but it also switched me out of doing a lot of these technologies, which we'll talk about in the end. And I couldn't disagree with them. They were right. Um, you just can't keep funding um, this type of work without actually proving it's got a clinical utility. So was the technology back in 2005 capable of doing, could double-blind clinical trials have been done back then? And I would argue strongly, yes. I mean, here's two studies where data was collected before 2005. I mean, looking at things uh, like neovascularization of stents was popular, and the and the acquisition rate was slower. And you could say that, was the technology as perfect as it is, or as great as it is now? Well, no. There's been 20 years of engineering of the technology, but was the minimal value product there? And I don't see any reason why it wasn't. So, and here's another example. Obviously, Peter Fitzgerald and Paul Yock, they pioneered IVUS. They're very well respected investigators, and it's a study um, uh, of neovascularization in or neointima in stent implantation. But okay, these are more, in my opinion, scientific studies. Do they change management? Are these actually management studies that are going to give us morbidity and mortality? And I would say no, and they just weren't being done. And this is not a criticism of, in the last slides, of any of these talented investigators then, but I mean, we needed the people who could actually do the clinical trials. So I'm going to bring these three slides, a couple on the period of 1993 to 2000, because I think it's important. So the team, basically the institute we established, it was Jim Fujimoto and myself. It was loaded with talented people, and that is one of the reasons why we moved so fast. And if you look through this list, even the students and the postdocs, I don't think you can consider these even vaguely average students and postdocs. These are stars, and they went on to great careers. And um, the uh, and we had strong clinical um, people, but I'm going to go into that in a minute, where um, where we went wrong. But if you, the other issue was, sorry, I have a little bit of a migraine. The other issue was why we moved so quickly is we had no competition. People did not believe that OCT could work in non-transparent tissue, like the coronaries, and MIT had actually given up the rights to OCT for non-transparent tissue. So the only group that really looked like they were potential composition was a group at NIH, very talented, with Schmidt and Bonner, but they were sort of focused on other things and never emerged. And by the time groups finally started emerging, we had developed a large institute. And even on this slide, you look at the technicians. Christine Jesser just had a JAMA paper out, and she was a technician at the time. So we had a lot of talent. But what's missing on this site is um, clinical investigators or clinical scientists, and we did not have them. And actually, our by around 2000, I was the last cardiologist, and to some degree, the last clinician uh, who took care of patients on any of the major studies, and most of them had moved to other sites. One actually died, which was tragic. And so, one of the points I want to make is that we needed, um, you need to go back to and forth between the hypothesis driven research. And I think this was a big difference between us and a lot of other groups and even some degree the ophthalmology work, is we were hypothesis driven, and there needs to be a back and forth. And I think that you could argue we went too quickly into the patient, because then a disconnect developed between us and between the basic science and um, the in vivo work to a large degree. It was almost as if it went into freeze mode. But first of all, it all started over a coincidence. I had decided the answer for identifying vulnerable plaque lied in a technology like OCT, and it dumb coincidence that right across the bridge was Jim Fujimoto, the Longfellow Bridge, and that was a pure accident. Um, he could have been in Texas, or I could have been working with an investigator in Texas. We had tremendous access to histology, except coronaries, which will come back to plague us. And we ended up developing our own histology lab, which did precision histology. This is critical. You need to match the histology to the image on a micron scale, and we developed very uh, sophisticated techniques for doing this. We built our own zebrafish labs and tadpole labs as we built acquisition rate and for assessing other things within right within the engineering space. We did the animal studies within the engineering space, though we did try to keep them to a minimum. I hate animal studies. Um, we had access to incredible laser technology. Jim Fujimoto, the chromium phosphorate laser, um, and particularly with Brett Boma running it, was really powerful. I knew a lot of the engineering and the quantum physics. Jim Fujimoto, it has a tremendous knowledge of clinical medicine, and that helped a lot too. Because when you just try to slam, like for instance, an engineer together with a clinician, I think it's very hard for it to work. But um, we, but like if in particularly in ophthalmology, uh, other than doing an ophthalmologic exam, I might ask Jim a question on clinical ophthalmology because his knowledge of it is so good. Um, so many people around 2010 started to doubt OCT as a viable entity, and this was based on um, conclusive studies not being done. Um, if I hadn't imaged so many coronary arteries and seen the correlation with histopathology, I wouldn't have believed it either. I would have started doubting it. And um, the and and honestly, when I raised the issue of outcome studies at times, um, particularly among the engineering and business community, but even with cardiologists, it felt like I was asking them to drink bleach. And the number of people who are afraid of double-blind clinical trials is amazing. So I got a lot of answers on alternative approaches. One was the thought of a Michael Jordan type approach, Michael Jordan with his sneakers. You didn't actually need to do outcome trials. If you get some prominent cardiologist to say OCT is great, everybody's going to start using it and it's going to get reimbursed. And the world doesn't work that way. The second view was, and some of these concepts I've heard within the last year or two repeated to me, not just 2 decades ago. The second was that OCT was like to treat it like car sales. If you could just find a feature to add to the device, clinicians will just love it and they'll start using it. And that may be great for car sales, but it doesn't work in medicine. And the third is our lack of linking with clinical um, trials experts. And to some degree, this was inexcusable because Brigham and Women's is loaded with talented clinical trials makers, and I'm not sure these particular ones would have joined, but like Chris Cannon, Michael Gibson, Deepak Bhatt, the, uh, the the Brigham is, Brunwald, Brigham is loaded, and we didn't take advantage of that. And the coronaries I will come back to, we should have pursued them more aggressively, matching them with histopathology, but we'll get back to it. But my vision for Light Lab, and this is speaking for myself, um, was to do outcome trials guiding stent placement as soon as possible. And then while we're doing guiding interventional procedures, learn about plaque, learn about these things, these scientific things, rather than having a company directed at science. And uh, the again, I just feel the technology was more than capable of doing it in 2005. So here are some of the areas that I really would like to run through pretty quickly, but I'm going to have to put some of them in the other slides due to length. This is going to run longer than I like anyway. There was a lack of double-blind clinical trials. There actually weren't any of it, and you would just get frustrated and frustrated at the papers that were coming out that just weren't going to affect our knowledge of its ability to affect morbidity and mortality. Image interpretation. We did not establish um, great correlation, massive correlation between large numbers of coronaries and OCT images. We had the lab to do it. We had our own histology lab. Our problem was getting coronaries. I get them now from Maine, and it's very difficult in Boston to get them because they use them in autopsies for diagnostic purposes, and we should have reached out and got it. We've came across ways to image through blood, and they got halted. So much of the research is not hypothesis driven, and there's no way around it. I mean, I trained basic and as a PhD and postdoc with including Nobel laureates. You need to do hypothesis driven research. I'm going to discuss clinical viability, the difference between having a product clinicians need versus making it over complex, the need for a guidewire and adjuvant approaches. I'm going to start with imaging through blood. I want to discuss it as an illustrative point because this is something we hit very quickly with hypothesis-driven work. So, this is from the first in vivo vascular study. It was done in a rabbit, but still, we stuck the catheter in, could see virtually nothing, injected it in saline, and boom, we could see through the artery and structures past the artery. So we could see through it, but, um, and I'm not going to go through the technique we used to actually catheterize the rabbit, but um, the the problem was, so why was blood scattering? Well, up until that time, it was believed the cell membrane, mitochondria, and even nuclei, which isn't an issue with red blood cells, was causing the scattering. And this, you so often you make quick calculations, and just the wavelength that we were using was too long that these really should have been scattering. And so what we thought is it likely had to do with the difference in refractive index between um, the inside of the cell and outside the cell. And if you don't know, you if you have two entities that have the same refractive index, light goes right through it. You don't get refraction or scattering unless there's a mismatch in refractive index. And refractive index is the speed at which light travels through a tissue. That's why when you look at a rock in, let's say, a lake, it's distorted its position because light is uh, direction is changed. But so we just did the first simple thing, put saline on a slide, measure the intensity off the reflector. Sorry, not a slide, a reflector. Put blood on a slide, the reflector was gone. Then lyse the cells. So if the mitochondria, the cell membranes were what were causing the scattering, it should be relatively close to the same. And when we lysed the cells, we got 70% of the saline back, and it was the intensity of reflection was the same as plasma. And we published this in um, 2001. And we called it index matching. And it turned out when we measured it, the extracellular refractive index was 1.35, and the intracellular was 1.50. And when we have that many red blood cells, um, it causes an enormous amount of scattering. And some people have now gone to calling this optical clearing, but the original name, and I think the more accurate name, is index matching. So we pumped blood through a tubing system with a reflector in it and saline through it, but then we're going to try things that raise the refractive index of the serum. So what I want, if people look back at this paper, we didn't look for the ideal compounds. I was going through the cath lab looking at what was expired, like dextran, IV contrast, and checking the refractive index. And here, it's just an example. If you use IV contrast, imaging through blood improves. Um, and this isn't from dilution. But so dextran was really effective in doing it, but we weren't even vaguely suggesting to use dextran. We were just proving the point. We weren't um, biochemists or organic chemists that could synthesize compounds. We had proved the point. The assumption was um, that somebody would come along with a compound that you would inject. And I want to go into the vision on this. So when I had thought through and had done these experiments, I envisioned this analogous to giving contrast in MRI or CT. You inject it, you can monitor the level of visibility of the red cells with a very simply made machine, and then go in and do your cath, and the blood is transparent. All right, and so that would make the procedure infinitely easier if you didn't need to flush with something saline or contrast during the OCT procedure. But this sort of went into a halt mode. There's not as much work that should be done on it. A huge issue is interpretation of the OCT images, and unfortunately, uh, this area sort of deviated where one of the problems was the engineering community was producing, correlations in what they were calling lipid plaque. And lipid plaque can be necrotic, it can be PIT, it could be a xanthoma. I don't know, you don't know what lipid plaque is. And we're looking for necrotic cores. Does that matter with, let's say, PCI with stable angina? And I'm going to argue just quickly, and this will be a subject of a separate talk, and actually I have done other talks on this. One area is just on no reflow. So yes, people who do or are familiar with PCI, you're not worried usually about acute occlusion. But the incidence of no reflow, which increases morbidity and mortality, in this paper is 32%, but I'll let other people read it. It's very reasonable to expect this has to do with plaque composition. If you just are injecting, and I'm going to show this on the next slide, a lot of lipid downstream, then it's going to cause occlusions in the distant vessels, and you're going to get poor runoff. And so, this would affect, if this pans out, and obviously, again, you want it to pan out in double-blind clinical trials. So, I published this paper with Kishore Hajar. It first started with a case. He hit a TCFA, which with the edge of a stent, and downstream, in spite of being, the anticoagulation and antiplatelets, the vessel occluded, and OCT was done almost simultaneously with the events. And what happened is, it's going to show it on two slides from now, but the edge of the stent, so the yellow was the lesion, the first red arrow is where the plaque, the TCFA, was ruptured, and then the second red arrow is where the clot formed. And I'm going to jump 2 slides ahead. I decided it's better to do this. So what happened is so you see the edge on the bottom, the stent clips a TCFA, but this TCFA, there were actually 2 in the fields. If you look distally, there's a second TCFA. The first one, though, is associated with a long necrotic core, and it evacuated the whole core. So if we go back now to the OCT images, so the yellow arrows is the TCFA that was ruptured, but if you look where the green arrow is, it's breaking into that necrotic core, and a lot of times it's just in direct communication with these long necrotic cores, and we see cores, like 30 millimeters long. And so, and you can see in the image in the right, it evacuated out the core, and there was just blood in there. So you may label this as a dissection. And at first, we wondered how critical was core evacuation in ACS. Now, I believe it probably plays a strong role in no reflow, but the problem in one of the problems facing cardiology right now is only 18% of TCFAs progress to ACS. And so you cannot call a TCFA a vulnerable plaque. Only 18% of them go to ACS. The rest just usually become stable plaque. And we thought, this is it. The ones with the long core do it, and they do it possibly by core evacuation. And in this paper, we've reviewed a lot of our previous papers, and we had seen a lot of our previous data is discussed in the paper. And we had seen these long cores and their ability to spiral around the artery in the 90s, and we just sort of looked at them and said, wow, they're pretty. And it actually, everybody, including us, had been looking at these plaques in cross-section, and it was their longitudinal extent that became important. But so core evacuation probably isn't a major mechanism. And I'm going to go into a 2019 paper that's going to discuss why long cores likely are causing ACS. But to an interventionalist doing a procedure, these areas need to be looked at in terms of their importance. And I'm going to argue that that in an artery like this, shown in this drawing, that you need to get a stent over an area downstream that has poor healing capability. So identifying plaque composition, and again, early data, which is what some people still use today, talked about lipid plaque. So what came out was that, and part of it is that there was a lot of an attempt to quantify. And as clinicians, we're used to dealing with qualitative data. When you look at an X-ray, you look at a CT, it's not about quantification. An angiogram, you look at it and qualitatively. And I used to read a lot more OCT images in comparison with histopathology, and would be able to easily pick out the difference between a necrotic core and non-necrotic core. But one thing that came up was that necrotic cores had a diffuse boundary between the intima and the core. And this made no sense to me, but we re-examined our data, and because if you put lipid oil, Crisco oil against water, you have a sharp boundary, not a diffuse boundary. So if we look at this plaque, this is a necrotic core. Okay, on the left where there's the yellow arrow, the border between the core and the arrow and the intima is diffuse, and this, by some people's criteria, would indicate a necrotic core. And on the right, which is the same core, the border is sharp. So the border diffusion is not being caused by the composition of the core. It's being caused by scatterers in the intima. So it's more likely, if you have a necrotic core, you're going to have lipid crests. You may have calcium in the intima, which is going to scatter. And so there's going to be some degree of correlation. But in my opinion, we need a better classification system. And plaques are just more complicated than necrotic core versus no necrotic core. So here, we're looking at a very long 10 millimeter plaque, and you look, and the black arrow, clear-cut necrotic core, and then the red arrow is closer to being PIT, and the area in between is controversial, but is a little bit difficult. But we're going to come back to this slide because as you see the core move up to the surface, one of the things that we realized was angiogenesis couldn't go through the core. It has to go around the core. And when the core is very long, vessels don't get there. And when vessels don't get there, cells that are needed for healing, smooth muscle cells and endothelial cells, aren't there for healing. And this just shows, again, a really long 40 millimeter core, and at points it gets very close to the surface. But to get blood supply to a lot of these areas is very difficult, and it raises the concern during PCI. Should the stents be covering some of these areas, or should we be using some tactic? But this needs to be studied. So ACS, so we proposed in 2019 that in the articles in JAMA Cardiology and Circulation that ACS was not due to plaque rupture. It was due to plaque rupture and failed healing. And one of the key points is when a clot forms, when a rupture occurs, the clot can take a day to a week before it occludes the coronary artery. But that's enough time for smooth muscle cells, endothelial cells, and other factors to get into the clot and stabilize it. But if you have no healing in that area, If you lost your blood supply, which is what our proposal was, as in this artery, the blood supply just stopped, then that area, there's no way to contain the clot. The clot is highly likely to eventually occlude the artery. And so this went directly in conflict with the current paradigms, which was that angiogenesis was bad. But when you look at studies with angiogenesis inhibitors for cancer, for instance, the mortality from clots increase, not decrease. So that data is consistent with our data. And again, we published this um, in JAMA and in Circulation in 2019. And this is a drawing, and this is not the drawing from the Circulation paper, which is still under embargo, and I will have it on the NIH webpage when the embargo is lifted. It's a similar though. But so when you have a long core, you see these blood vessels, they go around, and we figured this out by looking at several hundred histologic sections along with OCT images of them. And so, and they were special stained for things like von Willebrand factor. And so, if you can't get blood supply to it, can't maintain cellularity. When the rupture occurs, there's no way to contain the clot. Need for a guidewire. From day one, I believed in the need for a guidewire. Unlike this is original. I still have a bunch of these that are unused. There was originally a Light Lab catheter that was 0.017 inches. The optical fiber is about 120 microns in diameter with a 9 micron core, but that can be shrunk to 80 microns. And it's not like IVUS. You do not need a transducer, a receiver, or a producer of ultrasound in the catheter itself. All you need is to reflect the light in the catheter. So it can be made extremely small. So why is there no OCT guidewire? I don't know. Maybe somebody ran into a problem I'm unaware of, but I don't know why there isn't an OCT guidewire. So adjuvant techniques in clinical viability. I'm going to address the individual adjuvant techniques, and I'll list them on the next slide, but I'll go through them in a separate presentation. What I mean by clinical viability is, as somebody who does both engineering and the physics, but also is somebody who takes care of patients, clinically, simple is good. If if somebody said, we can give you glucose measurements to 6 significant digits, would you want it? No, I would rather have, no, it's 130 rather than 130.33333, and not increase the risk of false data, or it takes longer to actually get the data. So that's what I mean with clinical viability. And this hit a lot of these adjuvant techniques. So we work in all these areas, but some other groups do too. But one of the things we focused on is simple is better. As a doctor, if it gives you the right answer, and I'm going to use polarization sensitive OCT as an example. So polarization sensitive OCT measures collagen, and I'm not going to go into why now, but we use the simplest approach, and as far as I know, we're currently the only one that's done it. We've done it in vivo human joints multiple times. The surgeons read it easily. Other people are searching for absolute numbers, and the technique, in my opinion, that introduces that increased complexity, introduces artifacts and the complexity of the technology, but not necessarily for a reason. And I'm going to go through this on another slide, but there's OCT Doppler. OCT elastography measures the tensile strength of tissue, very important. Photon tagging, absorption spectroscopy. Entangled photon, I have entangled photon OCT, which is stupid on my part, because it's entangled photon spectroscopy. People call it quantum OCT, but it actually isn't even OCT. And second order correlation spectroscopy, which is a technology we developed, which I think will revolutionize the field. But all these, went to moving at a slow pace. And getting back to the concept that I talked about of clinically viable, if a tiger was running at you, would you prefer, and it was 100 yards away, would you want to determine if it's running at you or away from you, a laser Doppler or a pair of binoculars? Well, you would want the pair of binoculars because you could see the tiger's face running at you. The Doppler, if you've ever used Doppler in sports and anything, if you're off the target, you get false results. It's too easy to get false results. Simplicity is critical. Make it as simple as it needs to be to get the job done. That's what the beauty of O2 sat meters and um, capnography machines. Hypothesis-driven research is critical, and so much is engineering-driven. Build it, and they will come. And it's not you only engineer to the point of the need, but it has to be hypothesis-driven. And as somebody who's been on more than 80 NIH grant committees, the first way that grants get rejected is they're not hypothesis driven. It's not clearly linked to morbidity and mortality. It's just about building a technology. And again, it's not a substitute for morbidity and mortality data, these double-blind clinical trials. And so, when we've got to have strong morbidity and mortality data to know if OCT is a useful technology. Do I believe it's a powerful technology in clinical medicine? Yeah, I absolutely do. And from using it, I believe it will work. I believe it will revolutionize cardiology. But that needs to be proven. Till it's um, till that's proven, I mean, it's an experimental tool and it's a very impressive electronic device, but to be a clinical modality, we need morbidity and mortality data. And I'm mentioning my book, which I wrote in 2006, and the publishers keep asking me to write a second edition. And my biggest problem is between now in 2020 and 2006, I don't see enough advances. What I would add that much more um, to the book that I would change it significantly. And you see the sales on the books is still really high, and it's from 2006. And that's unthinkable in medicine. And if you'd said that, though, between 1996 and 2000, this field changed at a dramatic rate. So, um, some of this is my opinion, but you can look through what transpired and decide for yourself. But I hope this has provided some insights into the people who are now advancing the technology, the interventional cardiologists, the basic scientists, and the corporations, who have really given me a lot of enthusiasm that, we're finally going to get OCT as a powerful clinical modality. So thank you for your time.